So, good evening, ladies and gentlemen. My name is Ahmad. I am very happy to greeting you again, our new podcast and special podcast with special speakers and moderator, Professor Mazen Sinjab. I think we all know him. Professor Mazen is a leading ophthalmologist and internationally recognized expert corneal and refractive surgeon, known for his pioneering contributions to clinical practice and medical education. He has authored influential textbooks, published many papers in corneal topography and treating of keratoconus and refractive surgery. He has developed widely used surgical techniques and trained generations of eye surgeons across the world. His work bridges scientific rigor with practical innovation, making him one of the most respected voices in modern ophthalmology. Greet you, Professor Mazen. And our moderator today is Dr. Muhammad Husni Abdurrahman, is consultant ophthalmologist in the UK right now. Western Eye Hospital, Imperial College Healthcare, NHS Trust London. Mr. Hosni is specialized in corneal anterior segment and refractive surgery. He has trained and worked at leading ophthalmic centers, including Moorfields Eye Hospital, Queen Victoria Hospital, Birmingham and Midland Eye Center in the UK, and Parker Cornea in the USA, as well as a tertiary referral institution in Ireland and Ain Shams University in Great Egypt. His expertise includes advanced corneal transplantation, endothelial keratoplasty, keratoconus management, refractive surgeries, and complex anterior segment reconstruction. He's actively involved in surgical education, international collaboration, and advancing standards. So thank you very much. Thank you for our attendees. And we start. I give you the word, Mr. Hosni.
Assalamu alaikum. Wallah, it's a great pleasure and honor to give you the opportunity, Dr. Ahmed, to moderate such a great podcast and Zoom meeting with my one of the fans, somebody who's one of his own fans, like through this own thousands of fans, and someone who have been learned from him a lot, Professor Mazen Sinjab. Like, of course, we have all learned from his books, his lectures, and he's one of the pioneers in the refractive surgery worldwide. Thank you very much for this opportunity today. And I was having a lot of questions and a lot of queries and stuff to ask, but like we just decided that Professor Sinjab will start his presentation, and he will talk about each case. And the good thing about the meeting today, it will be like kind of, we have all to share and take opinions. Don't think that your opinion could be like, is not important. Every opinion is important, and you can come with an idea which nobody think about before. And the good thing, Professor Sinjab give me a promise that whoever do the right answer, he have a very good price for him, isn't it, Mr. Professor Sinjab? Yeah, you told me so.
Yes.
Yeah. So would you please just you can start if you kindly your pleasant presentation, please.
طيب جزاكم الله كل خير. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Hello everybody. First of all, I'd like to thank the Arab European Ophthalmology Society for inviting me to such a very nice session. And it's a great pleasure and honor to be with both pioneers in the field, Dr. Ahmed Rahal and Dr. Muhammad Husni. They are my great friends, and I'm excited today to exchange my skills and experience, and to learn from each other. And thank you, of course, both for the very nice and kind introduction. So for the sake of time, I'm going to start sharing the screen and start with the cases. How we are going to go through today is I'm going to show you cases and do some discussions. And if you have any questions, you can ask immediately in the chat box, and immediately I can answer about each case by its own. And at the end of the session, if you have any questions, of course, my friend Mohammed Husni will take these questions and we will answer, inshallah. So no worries, we will not leave the session until we have answered all the questions, inshallah. So I'm going to share now. بسم الله الرحمن الرحيم. اللهم احلل عقدة من لساني يفقه قولي. اللهم اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقه قولي. يا رب. بسم الله. Now, as you see here, not here, sorry. This one. Now, this is the first case. As you see here, this is a case of topography. Now, what do you notice in this topography? Do you notice something abnormal or something alarming?
So far, it looks okay.
Okay, now let's go step by step. First of all, this capture, although it looks like normal, okay, here, as you see, the QS is okay, but I don't accept it because the pupil is dilated. All right, the pupil was dilated when taking the capture. So the information, many information will be false. So in this case, we have to repeat. Now, let's assume that this is the usual size of this patient pupil. Okay, let's assume that. So let's go for the other, let's say, alarming sign, which is the very high thickness of the cornea. So in this case, what should I have a doubt about?
You should doubt about some corneal disease, or if it's like the pupil size is fine and everything is fine, something that makes the cornea thick. Let's see if there is like Fuchs dystrophy or something.
Yes,
It's
exactly. This
the
is what I
thickness is,
wanted.
yes.
Yes, exactly. This is what I wanted to highlight, that it might be normal, but it might be abnormal. That's why we have to check the patient again, maybe on specular microscopy, maybe on the slit lamp again, maybe it is a slight edema, maybe Fuchs, maybe whatever. So this is what I wanted to highlight. Otherwise, it is symmetric bow tie, as we see here. It is symmetric bow tie, and there is no skewed radial axis here in the inner part of the bow tie. Now here we have to be sure that it is 8 millimeter diameter, and if we are studying the best fit sphere, then we have to look at the thinnest location. The thinnest location here, this one, the number corresponding to the thinnest location. So here it is +7 and +3. Of course, we cannot interpret without asking about the refractive error of the patient, because this is the best fit sphere. Okay, so everybody knows the cutoff values, so I'm not going to go through that. So in general, it is normal case and symmetric. Perfect. Now, what other maps that we have to check? We have to check the Bellin-Ambrosio display just to see if there is any warning here. It seems it's fine. However, we cannot rely on this completely because sometimes there are false positives or false negatives. But at least if there is something warning like yellow or green or red, then we have to recheck again and to be careful about interpreting other maps. The most important actually is to check the spatial profile. All right, the spatial profile, and the reference is 6 millimeter. So if this red line is consistent like in this case, then it is fine. And we look at the average, it should be less than 1.2. So as we see, everything is perfect in this map as well. Now we go to the holiday report. Holiday report is important for the best fit toric ellipsoid at 8 millimeter. And here we have to look at the central 5 millimeter, not the dotted. The dotted is the pupil, so it is not the reference. So the 5 millimeter, central 5 millimeter, here we don't ask about the refractive error. Any number within the 5 millimeter on the anterior should be less than 12, and any number on the posterior within the 5 millimeter should be less than 15. So as we see here, plus, of course, n plus, not n minus. So as we see here, everything is perfect in this case. What is very important as well is to check the curvature map, anterior, tangential, and the relative pachymetry map. Why these two are very important? Because if the patient had previous laser procedure like PRK, SMILE, LASIK, femtolasic, whatever, these two will show some signs, all right? And everyone should know these signs through my books and my YouTube. And why this is very important, especially if the patient is coming for clear lens extraction or cataract surgery. So we have to go for biometry. And if we did not recognize any treatment before, then we are going to use the wrong formula and we have a post-operative refractive surprise. All right, so this is for this map. Of course, this is just an appetizer before we start the cases, just to let you know how we read these. And it's very important for the inferior superior asymmetry to go to this map, which is the topometric map. The topometric map here, there is IS, inferior superior. So this is the most accurate number, which should be less than 1.45. So 1.4 and less. Because this number measures the 5 points above the horizon and the 5 points below the horizon, and the average of the above and the above average of the below. The inferior minus superior should be less than 1.5. While if we look at the traditional way, which I usually describe, in case you don't have this map, okay, what is the usual usual way, is to look at the second circle, this one. Second circle, not the inner one, but the second circle. The two opposing points at the steep axis. And the inferior should be, let's say the inferior minus superior should be less than 1.5. But this is against the rule or with the rule astigmatism. What do you think?
Yes, with the rule
With the
astigmatism.
rule.
Exactly, this is with the rule. But what if it was against the rule? If it was against the rule, you wouldn't be able to calculate it simply by taking this one and this one. That's why it's very important. If you want to have accurate answer, then you have to look at the IS and the topometric. All right. And as well, if it was oblique, you cannot. Okay, now let's move to this one. Now, why this is very important? Because if a patient comes for multifocal lenses or EDOF lenses, then it is mandatory to check the corneal wavefront. And of course, the corneal wavefront should be studied at 5 millimeter. Here it is 6. This is the old concept. Now, the new concept is to 5 millimeter, central 5 millimeter of the cornea. All right. And we click all off. First, you have to be sure that it is wavefront aberration of the cornea, not front, not back, not elevation. Okay, it is only wavefront, all cornea. So this one should be marked here. All off, and then we click N3, and the center of N4. So these are the 5 high order aberrations that I have to consider all together. How I look at the RMS here. The RMS here, okay? The RMS here should be less than 0.35 micron if for multifocal, and less than 0.5 micron if for EDOF. Otherwise, if it is more than 0.5, then we can put only enhanced monofocal. Enhanced monofocal. All right? Now, what are these? These are the vertical comma. Okay, here. This is the vertical comma and horizontal comma. The vertical trefoil and horizontal trefoil. And this is the spherical aberration. These are the most important. Okay, and of course, I created the PSIS algorithm. I think you can find it in my YouTube channel as well and in my books, for sure in my books. It is an algorithm that I created to help you to choose even the monofocal lenses, because we know that the monofocal lenses are either spheric or aspheric. All right, and the aspheric, they can be neutral, no spherical aberration induction, or maybe negative 0.2, or maybe negative 0.27. So you can choose amongst all of these just based on looking at this number of the spherical aberration, which is this number as well. This is the spherical aberration. Z40 is the spherical aberration. Super. So again, this is just an appetizer. Now we start with this case. This patient is coming for refractive surgery. This patient has -2 sphere minus, let's say, 1.25 at, okay, maybe at 5 degrees for this eye. So what do you do?
First, the thickness is 475. This is not for LASIK, but before we need to check the accuracy of the pentacam. It's not that still it's like in yellow, but the thickness, this is not, we can exclude LASIK from the equation anyway. That's number one.
Okay. Number two, we'll check the operation because it's here. Maybe it's at a comma form. I think so.
Okay. Now let us see. How about PRK? How about PRK here? Can we apply PRK?
Okay. I would see. Okay.
Yes, Dr. Muhammad.
Yeah, because of the corneal astigmatism and how regular, it's not that bow tie too much. Still, I can see the number. Maybe I can't see so much. But before we were saying, you were considering before, like if it's 2.5 difference in the upward, but you stop doing that. You just say it should be 1.2, 1.5 inferior superior. But it's kind of irregular. Like, let's see why it's like this. So there is some. It's not that bow tie, like that regular bow tie, that I need to have some suspicious about. Yeah.
Okay. Now, always when we study or we interpret pentacam altogether or any topography, first we have to check the quality. The quality is bad. Data gap on the posterior and data gap on the anterior. We repeated this plenty of times, but still giving this. And here I want to say why it is giving this, why we have this shape of irregularity. This is the corneal thickness. Okay, why we have this blah, 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 like this.
Like clinically, Dr. Sinjab, is he a contact lens wearer? He have dry eyes, he have some pannus around something in the cornea clinically can justify this, what's happening?
Yeah, amazing. Actually, whenever you see this pattern, especially this one, when you see this one, look at this. At the periphery, there is something giving this problem. Okay, there is something at the periphery, this irregularity because of something at the periphery. Look at the other eye. Wait, we have to remove this first. Okay, now the other eye, same. Now look at the cornea. What do you see?
That's arcus senilis look like.
Exactly. This is the reason. Now, what else where we can find arcus as well, but in young people?
Arcus
Well,
juvenilis,
Lipidos.
like high lipid.
and what else?
If you have some, it's not arca, but like lipid deposition can have like previous infection.
Therian dystrophy.
What else?
VKH.
The VKC, you mean?
Rheumatic.
VKC?
By
Or what?
keratitis.
But it won't
Exactly.
give this appearance. It won't give this.
No,
No.
in VKC,
VKH اللي هو young juvenile arcus.
yes, okay.
Yeah, that's right.
But apart from the arcus itself, the juvenile arcus and lipid deposition,
Marginal keratitis.
in VKC, long-standing VKC, you will find something similar at the periphery of the cornea, and this is the main reason, sorry, why such people may show keratoconus, may show false keratoconus. So sometimes you may find very steep cornea in the center because the cornea at the periphery is not normal. And this will show keratoconus, while if you treat the patient properly to stop the itching and to treat the papillae at the limbus, all right, of course, it will not be there will not be an opacity as bad as this one in VKC. It will be very faint, a very faint one and very peripheral, but it will have its effect and will give something similar to the keratoconus. That's why when we have any peripheral opacity or pathology, first we should not, if it can be treated, for example, the VKC, we have to treat it first, beat it first, and then recapture the patient. I have some cases of children, they showed keratoconus, and after treatment of the VKC, especially the limbal VKC, the cone disappeared. So just I wanted to show you this just to highlight that peripheral lesions may cause false information from the center. So in this case, we cannot say, we cannot depend on the picture itself to say we can do PRK, even topo-guided treatment, we cannot do it because the information are false. We just keep the patient on glasses or contact lenses. All right, don't touch the cornea because these information are abnormal. But what if the patient wants to go for cataract and they have such a problem? Then what should you do?
After treatment, you can treat him as if you have something in the cornea. LASIK previously just use maybe Barrett True-K with the true posterior corneal refraction, like astigmatism?
Yeah, very good. Actually, the optical devices, they take the central 4 millimeters. So they are not affected by this peripheral lesions, okay? They measure only the 4 millimeter, central 4 millimeter, and they measure the K readings according to that, as you said, true K with Barrett is the best in such cases. Any questions so far? Yes. Now, regarding toric ICL or toric lenses, toric IOL, there is a question here. Of course, if you take the central 4 millimeter with the optical device, then yes, you can depend on the reading of astigmatism with the optical device, but not with the topography, because the topography, the center interpretation is very much affected with the periphery. So you cannot take the astigmatism from here, simply from here. You have to take it by the optical devices, IOL master and whatever. All right? Or otherwise, you can take monofocal without toric. And of course, such patients, we cannot go for multifocal lenses at all, and neither EDOF lenses, because they are very irregular and wrong measurements. We cannot depend on the measurements. So better to go for monofocal lenses. Now we go to this case. This is another case. So what do you think about it? I'll show you only one eye. This is the eye, and the other eye is similar to this. So what do you see in this case?
This again is the rule, astigmatism, and it's not so much bow tie.
It is inferior steeping.
Good.
Like the posterior elevation map is fine, anterior elevation is fine. Sagittal just have this kind of definitely the thickness is not for LASIK, and of course it's okay regarding the like the like kind of the good
This
quality.
one. Yeah.
I would have a look as well as the holiday, like the toric ellipsoid as well, to check how it goes.
Unfortunately, I don't have it.
Okay.
But always when there is some irregularity like this type, okay, like maybe it is going to be crab claw, as you see. Okay, you see, this is going to be like crab claw. And when you see this, so maybe it's an early keratoconus. So in this case, maybe. In
Maybe
this
check
case,
the other eye just in case. Maybe it's like a form frost or something. Check the other eye.
yes, of course. And I check the posterior tangential map. This is very important because there is no early keratoconus without affecting the posterior surface. The posterior surface should be affected. And the most sensitive map to check the posterior surface is the tangential posterior curvature. Now, as you see, it is symmetric. There is no asymmetry in the posterior surface. Therefore, it is not keratoconus. It is just there is abnormality on the anterior surface. And it is not associated with focal thinning in the epithelial map. I check as well the epithelial map. Now here, there is focal thickening. Look at this. This is 45, while here it is 49. Sorry, here it is 54. Here it is 54, while here it is 49. So this is thickening. And always when we find steepening with thickening, it is contact lens effect. The patient is using and has been using contact lenses. So not every steepening is an excuse to take the patient to the operating room. No, first they go to the accountant to pay money, and then to the operating room to do cross-linking. Okay? So it is not an excuse to take money because I want to buy a new car, all right? Or I have a house with loans. I have to pay for the loans. All right? This is the message from this. Now, moreover, we look at the keratoconus display. The keratoconus display is very important because this is the same case. Because when we look at this black line, it is consistent with the other lines. So no keratoconus with consistent spatial profile, no keratoconus. And we look at this. There is white circle, as you see, and two ellipses, yellow ellipse and red ellipse. We don't care about these two ellipses. We care about the white circle. The white circle is for the measured cornea. And it represents the collection of all high points from all of these maps. All these maps, the highest points in all these maps, they are represented here. And the white circle gathers all of them. Now, when this white circle is very wide, all right, when it is wide, like in this case, then let me maybe show it to you. No, I cannot. Okay. So when it is wide, then it is a normal cornea. When it is very, very small, then it is an abnormal cornea and most likely to be keratoconus. So as you see, this is not keratoconus. It is just because the patient has been using contact lenses. And at the same time, I cannot take this patient to PRK because it is not keratoconus. So, okay, great. Let us go for PRK. No, because we have first to tell the patient, stop using contact lenses for at least 1 week, use lubricants, come back again, and then this should disappear. It must disappear before we touch the cornea. As long as this is here, I don't do anything to the patient. Even if the patient says, look, I want to travel, look, I don't have time, look, I'm going to another center, okay, please go, goodbye, because we cannot do on false surface. This is false surface. It is not the real surface of the cornea. This is not the real surface of the cornea. Thickening and steepening is because of contact lenses. So we cannot treat such a patient until we treat the dry eye and at least 1 week of no contact lenses. Now, what do you think this patient is suffering from? What type of aberrations? Before I show you the aberration.
Probably coma.
Exactly. Is it vertical coma or horizontal coma? Or both?
Look like it's horizontal.
Let us see. This is the same eye. This is the vertical comma. It is 0.432, which is very, very high. And this is the horizontal comma. It is 0.317. So both of them, of course, the horizontal is borderline, but the vertical is high. And look at the RMS of these five. These five, okay? This is the RMS. It is 0.564. So neither EDOF lenses nor multifocal lenses can be implanted in such a case if it was cataract. All right? So as you see, we can get benefit from every single number, every single map in the topography.
Professor Sinjab, I have a question.
Mhm.
Do the same criteria for presbyopia with laser, like Presbyond?
Yes, same. It is because presbyond is LASIK. At the end of the day, it is LASIK. So same criteria.
Yeah. So you mean we cannot ablate this type of aberrations through the presbyond therapy additionally?
No, because presbyond is based on anisometropia and increasing the asphericity of the cornea, the spherical aberration.
Sure.
And as long as the coma is there, it will complicate the case. It will make it unpredictable, and the patient, because already has high coma, and we are going to increase the spherical aberration. So it will be more and more complicated. So always we have to treat the cause, contact lenses, stop contact lenses. And of course, you have to have Quran, Bible, whatever in your clinic to let the patient swear that they stopped the contact lenses really 1 week before. Because I have a doubt. Whenever they have an occasion, they will put it for just 2 hours and they will say, oh, what will happen? 2 hours, what will happen? And even if they swear, don't believe them. Okay, let's go for the other case. أيوان هون حطنا الجمال. يلا, what is this?
طيب, so far the only two positive things is the first of all, like the thickness, like we cannot do LASIK for this patient. Of course, here if we can say that the sagittal map, like it have kind of just one diopter difference, but still there is something going here. The cornea thickness have this kind of donut shape a little bit, like I would see the maybe the tangential map as well, and ask about previous any LASIK correction or something before. No,
No previous laser correction.
okay.
I think everything is okay, just we cannot do laser.
Okay, don't you think that there is some
we have sure here
abnormality here?
inferior steepening.
No scarring.
Yes, steepening as inferior.
Yeah, there is steepening, yes.
Yes.
But I was answering the question from Tamara. She
Question
says
from
any
the chat,
scarring?
sorry.
No scarring. Yeah, there is steepening.
Let's take the other maps as well, like yep.
Yes, this is crab claw. All right. Do you think there is something abnormal in the thickness map? It is going down. Why?
Is it
You
not
see
very
the-
early precede margin degeneration?
Exactly. This is early pellucid marginal degeneration, and the other eye shows it very frank. This is the other eye. Crab claw with bell sign. It is like a bell because of the inferior band of thinning. All right. So it is pellucid marginal degeneration. So always pay attention to abnormal patterns, especially something going down. You see, something going down. Something going down. All right. Now, do you do cross-linking for this patient? The patient is 55.
Yes, definitely. Bilateral
Super.
cross-linking.
Yeah. Absolutely.
Not because of the car and not because of the mortgage.
Exactly. But because it is progressive forever. You do not need to document progression for PMD. Now, if you want to apply the spot of cross-linking, where do you apply it?
like on the area, keep it down as much. Even if you will keep on the limbal still, no worries. Like you have plenty of limbal still, just keep it at the thinning area.
Exactly. So we make it decentered, and no worries about killing the stem cells in this area because still we have 3/4 intact, and they will compensate for that. Why we should do this? Because if we make it only central, then in this case, it is a peripheral degeneration. So in this case, we will not have any effect. Now, if we want to implant the intracorneal rings, then what consideration we should do?
Like this is a very thin area. You mean rings, or like you mean the Kers?
Kers, for example.
Okay.
Kers, you can implant here, no problem. But
yeah,
if the rings, you have to avoid the cone itself. You have to check the cone. Of course, checking the cone is just by the Gaussian map. Gaussian map is given by Cyrus and MS-39, not by the Pentacam, unfortunately. So this is another story. We can talk about it in another session. But to highlight, we have to avoid the cone itself when we put the ring, because if we go through the cone, then there will be no effect and there is a risk of perforation. And if we want to do keratoplasty, so what consideration as well?
I will do keratoplasty after the cross-linking. And
exactly.
Yeah, because like it will be very soft.
Yes.
That's number one. And I'll try to keep it a little bit decentered as well, like if I can.
Yes, exactly. I do agree with you. Super. Now we go to the next case. Okay, this is the anterior tangential. This is the corneal thickness map. This is the anterior elevation and posterior elevation. So what do you think?
Posterior elevation, is he myopic or hyper, or it doesn't say?
He is myopic.
Okay,
Look.
so he looks like having definitely like abnormal corneum, and the posterior tangential map shows changes.
Yeah, but we don't have
Guys,
here the posterior tangential. Let us see the posterior tangential. This is the posterior tangential. This is the anterior sagittal, and this is the posterior tangential.
Definitely, there's some
You
changes
see?
here.
Asymmetry. So there is abnormality on the posterior surface. And there is abnormal on the anterior surface. So it is keratoconus.
Yep.
All right. Look at the focal thinning and the epithelium. This is the epithelial map. There is focal thinning. All right. Great. Now look at this. Look at the white circle. You barely can be seen. It is very small. Here, it is very small. And look at the line. It is a quick slope. And this is characteristic for keratoconus. You see? Great. Now, how to monitor progression? Now, this patient is 31 and he is a male. So, no pregnancy. So, in this case, do we think about the car and house, or we should monitor?
I would monitor.
Amazing. How do we monitor?
Like you have either to monitor them every 6 months to 12 months using the monitoring here in the MS-39, or to use the ABCD one in the pentacam if we have it. That's good as well.
For me, I will ask about progression in the history firstly, and then can I fix dates of follow-ups, 3 months or 6 months or yearly?
Probably I'll
Amazing.
treat the cause as well if he's still rubbing his eye. Like he's 31 doesn't mean he doesn't get allergies, he doesn't get problems.
Exactly. So we have to tell, please stop itching.
Mhm.
And this is
Atopic.
the ABCD. Yalla, Dr. Muhammad. There is progression or not? 6 months in
So
between.
yeah, let me see here. So the A should be 2 of them over 80%, and the B should be 1 over 95%. I think there's 1 over 95%. So I think there's progression here.
Exactly. So either 2 of them beyond the 80%, the red flag 80%, or 1 beyond the 95%. So we have this, it progressed from the yellow. Forget the blue. This is by mistake. So we have the yellow and we have the green. So the yellow is the first visit. The green is the second visit. So as you see, B, which is the back curve of the cornea in the 3 millimeters around the thinnest location. This is the principle of the ABCD. So it has progressed beyond the 95. This is the red flag of the 95. So there is progression. All right. Or 2 of the indicators, any two indicators should go beyond the 80%. So this is progression. So in this case, yes, we do corneal cross-linking. Now, let's assume that we don't have this. One of the colleagues put that we have to check Kmax and thinnest location. Yes. If we don't have, then we have to compare the Kmax and the thinnest location in the visits. If Kmax changes by more than 1.5 diopters and the thinnest location becomes thinner by 15 microns or more, in this case, it is progression. So we have 2 indicators together. If Kmax changes alone, but the thinnest location not changed, then it is an artifact. We do not rely on a change in only one parameter. And this was a major pitfall in the old studies where they depended only on Kmax in describing progression, and accordingly they did cross-linking for patients, which means thousands of patients in old studies were cross-linked without being certain it was progression. All right? Any question so far? Muhammad Husni, Ahmed Rahal.
Any
We
question
cannot hear you,
from the participant? No.
Muhammad Husni, we cannot hear you. No, we cannot hear you, Muhammad Husni.
There is a question, Professor. How much should the Kmax change in such case?
1.5 diopters.
1.5, okay. Another question, is this finding in older age with no progression? What about toric IUL?
Yeah, the toric IOL can be implanted if we are sure that let's say the irregular astigmatism is minimal, because in many cases we cannot implant toric IOL in advanced keratoconus or even moderate keratoconus because the cone is very much skewed.
Can you hear me now?
Yes, we
Yes.
can.
Oh, thank you very much.
What is your experience, Professor Mazen, with toric IOL as off-label use in keratoconus?
Yeah, I implant toric IOL usually, but there are many considerations. Like we have to use the Kane formula and Barrett True K as well, and compare both of them to be sure about the accuracy. Second, we should do cross-linking first, even if it is stable. Why is that? Because the keratoconus will change itself after cataract surgery because of the incision itself. Even if the incision is very small, it will change because it is very loose cornea. So we have to do cross-linking, wait at least 6 months, and then do measurements to implant toric IOL.
that
Yes.
that can open something very, very important. I was just talking with my colleague Muhammad Gamal today. For example, I have a patient who is a keratoconus, and she was asking that, for example, she's on contact lens, she sees 6/6. That's an example. On glasses, she sees 6/12. And I give her the option, like, if you are happy with the glasses, I can just put a toric lens for you. If she say, okay, I'm happy with the glasses, and after a while she say, I want to come back to the vision that I used to have with the contact lens. At this time, what kind of LASIK I do? Is it a custom LASIK or is it a topo-guided LASIK?
Yeah, it is. The custom PRK, trans PRK topo-guided or trans PRK corneal wavefront guided.
Yeah,
either one of them.
I will not do the ocular wavefront.
No.
Okay.
No. Only the corneal.
But that won't change, for example, the refraction, because already there is a toric IOL inside?
Yes. That's why after the operation, if you implant toric IOL, you cannot use contact lens. Even contact lens cannot be used because the contact lens will uncover the toricity of the IOL itself, the toric IOL. So if you put the contact lens, then the patient will suffer from astigmatism.
Yes. So you recommend in this particular situation, if she changed her mind after a year, I do a topo-guided LASIK, and whatever correction I have to correct it somehow after.
The aim is to treat the coma. Okay, the coma in this case. And of course, this may affect the astigmatism, but then she can continue with glasses for the astigmatism that you are going to induce. So that's why it's very important to discuss the full plan with the keratoconus patient before doing anything. That if you want to do this, then we cannot do that after, or we can do that thing after. So there should be the full sequence, and options should be very clear to the patient from the beginning.
I'm sorry for being sounding a little bit silly. That I say if I do ocular wavefront, is that will not correct as well the lens inside the what's happening that I put myself?
Yes. Actually, you will not take valid captures of ocular wavefront because you have toric lens inside, and maybe it is decentered a little bit. In addition, you have a problem in the cornea, which is distorted. So I have a doubt that you are able to have valid captures because you cannot go for any customized treatment, whether it is ocular or corneal, if you don't have valid data. All right. So with this complex, I have a doubt that you can do the ocular.
Yeah.
Thank you. We have some question in the chat.
Treatment of coma, cross-linking after 1 year, IOL toric. Yes, if the cataract is very, very mild, in this case, yes, better to treat the cornea first and do cross-linking, of course, and wait for 1 year or 6 months, let's say, and then you can have much better results if you put the toric IOL. If the sequence is cornea, then the cataract, it would be much better than cataract than cornea.
You do cross-linking
Yes.
every time before cataract surgery in
Yes, it is.
keratoconus?
If I'm going to put toric lens,
Only for toric lens.
only for toric lens.
And
But if it is usually what is recommended for the cataract patient with keratoconus is to go for the neutral aspheric monofocal lens. Neutral aspheric monofocal lens. In this case, you will have no problem. And even if you want to do topo-guided treatment later or corneal wavefront later, it will be much easier than if you had implanted toric IOL.
Dr. Mohammed Lubad, he was asking if you can put an EDOF in this kind of patients.
No.
so no EDOF in keratoconus.
Yeah, no.
Okay. Question from me: if you have keratoconus with high values, and you will like to insert a toric IOL, do you give the full correction which you got it from Kane, or you reduce it a little bit?
No, we target, very good question. We target minus 1.5. Okay, we target. So we do overcorrection because usually in keratoconus there is hyperopic shift. So we compensate for that by targeting minus 1.5.
As overcorrection.
Yeah, overcorrection, yes.
Overcorrection spheric or for the toric component?
No, spheric.
Spheric.
For example, if the formula shows that we have to implant 20, I put 21.5, for example.
Yeah.
That's correct. And for the cylinder, you give the full cylinder correction calculated with Kane.
Yes.
Thank you.
Yeah. Dr. Fadi here is asking about the eye Hans, like it should be okay with this?
Yeah, Eyehance, EMV from Rainer, they are enhanced monofocal lenses. They are good. But the problem, they induce asphericity. The Eyehance negative asphericity, while the EMV from Rainer positive asphericity. The problem is the patient with keratoconus is suffering from asphericity as well. So always, if I'm going to go for monofocal lens, it would be much better to go for neutral aspheric. Neutral aspheric. Neutral aspheric is available in the market. It induces zero asphericity. So if there is even decentration of the lens, it will not affect the patient, will not complicate his case.
We have another question from Dr. Hosni. How to evaluate cases with severe keratoconus or after cross-linking with some scars? Sometimes we see variation in measurements.
Yes, very good question. We cannot, because the scars will give false readings always. But anyhow, the scar mean the cornea is stiff. So don't worry about the cornea when there is a scar. It is stable. Anyhow, there will be no progression.
Thank you.
All right, so we can move to the second case or fourth case.
Yes.
Now we have this case, and I'll show you all maps, both eyes. So this is the right eye. This is the PAD of the right eye. This is the holiday report of the right eye. This is the topometry. This is the posterior tangential and the epithelial thickness map. And okay. And this is the aberration map. The RMS is 0.68. So we have this. We have this one, this one, this one. This is the posterior tangential, this one. And the epithelial thickness map here. And this one. This is for the right eye. Let's see the left eye. Of course, while you are seeing this, we want to know whether this is keratoconus or not. And if not, can we do LASIK or not for -2 sphere, -1 cylinder? Now, this is the left eye. This is the posterior tangential, huh? Not this one. This is anterior. This is the epithelial thickness. Here it is 0.56. Okay. Is it keratoconus?
Like so far, I cannot find something that says keratoconus. Even, yeah.
Exactly. This is the first message, take-home message from this case, because unfortunately, many surgeons, when they see this, they take the patient to accountant and then cross-linking. All right? Which is wrong, of course. Because not every asymmetry, this is asymmetry. Look at this number. It is 48.3. And this one is 46.9. So the difference is 1.4, which is still within normal. So it is not significant asymmetry. Good. This is for the right eye. And since it is myopic, the cutoff values 0. Here +5 and here +14. Both of them are within normal. Now, of course, we have to be sure that this is 8 millimeter, huh? Because sometimes they print it as 9 millimeter, which is wrong. We cannot read 9 millimeter. We come here. So here, okay, here, okay, okay, here, okay, and thickness is 552. KM is below 47. Sorry, this is pentacam, so below 48, which is okay. So all is okay. Now we look at this one. All right. This is borderline, the average. It should be less than 1.2. It is 1.27. And here, there is a slight descending before the 6 millimeter, but we can consider it normal. So the only problem here is the average.
The KMX is borderline too, huh?
Yeah, but we don't look at Kmax anymore. We look at Km. Always. K-mean. We look at this one. Don't look at Kmax anymore.
Yeah, Dr. Noor was thinking that it may be a pre-keratoconus.
No. Or maybe you mean keratoconus suspect, where there is abnormality on the anterior surface while the posterior surface is normal. We call this either keratoconus suspect or form frost keratoconus. Form frost keratoconus when this eye has this problem while the other eye has frank keratoconus. But neither eye has frank keratoconus, so it is not form frost keratoconus. Now, Is it keratoconus suspect? Let us see. Keratoconus suspect, then the anterior is abnormal. To say anterior is abnormal, either there is a skewed radial axis, here there is no skewed radial axis, or there is significant asymmetry. Here there is no significant asymmetry, so it is normal. All right, so it is as well not keratoconus suspect. So don't look at colors, only at colors. We have to look at numbers. But anyhow, we have to look at the topometry map. The topometry map for the right eye, the asymmetry is 1.34, which is normal. So as you see, the right eye is absolutely normal. Now we come to the posterior tangential map of the right eye. A beautiful symmetric bow tie on the posterior surface, so no keratoconus. A beautiful homogeneous epithelial thickness map. So everything is normal in this case. Now we come to the high order aberrations. So it is above 0.35. So if it was cataract, we cannot put multifocal lenses. Now let's see the other eye. Is the other eye eligible for LASIK or PRK or whatever? Let us see. 48.1, 46.6. So it is 1.5. So it is at the cutoff value. Here it is +4. And here it is +16. Because it is minus, so it is still. Here the pattern is concentric. The thickness is good. Km is below 48. So we are all good except this. Now we come to this one. Again, we have this. All right. And here a slight descending before the 6, which we can ignore. So we have only the average, which is high. So to be sure, we have to look at the posterior tangential map. This is holiday report. In the holiday report, all numbers here are within normal. Below +12 and below +15. Okay. The average here is 1.54. As we mentioned before, it was 1.45 roughly, but this is more accurate. Let us see this one. We cannot say that this is an asymmetry or significant asymmetry. Maybe it is something early. All right, maybe it is something early. And the epithelial map is homogeneous. So before this, let us see if the patient is suffering from something. Yes, vertical coma. All right, and the RMS is more than 0.5. So even EDOF we cannot put. Okay, but how about doing LASIK? Do you do LASIK for this patient? Both eyes, they have -2 sphere and -1 cylinder. Do you do LASIK?
Yeah. If the ocular surface is fine and he can have LASIK, but like if he's happy for PRK as well, why not?
Yeah. Actually, in this case, I would go for surface ablation. Yeah, just to be on the safe side. I don't like to cut a flap with such a cornea where the average is borderline. The average is borderline. I know it is only one factor, but usually when I see something that I'm not comfortable with, if the ocular surface, very good point, if the ocular surface has dryness, I would treat first. But if not, then I would say better to go for surface ablation.
Dr. Tamara is saying I would do film to LASIK.
It is not wrong. Okay, there is nothing frank that it is an abnormal case. Okay, it is not nothing frank. But when you see such things, you maybe would ask about family history of keratoconus. But if they say no, it does not mean that they don't have, because in many cases, after we have done LASIK to some people, the brother or sister, they come for consultation and they have frank keratoconus, and then you have a nightmare because
Yeah,
you did already femtolasic to their brother or sister. So,
yeah,
and they stay stable forever. So it
yeah.
is just like likely or probability. It is not certainty. Can
Dr.
we have this
Muhammad,
one?
Two
Yes, we
questions.
can.
just Dr. Muhammad Ahmed is checking, say why you don't do the biomechanics in this kind of patients, like with Corvus or something like that.
Usually I do this because we have all machines in the hospital, but we cannot say to everyone to have Corvus because it's very expensive. But in case you don't have Corvus, then you have to try to find clues. Like, do you have family history? If they have any ocular surface disease, if they have rubbing, okay. So it's not mandatory to have biomechanics.
Yeah, and for Smile it's the same. Like I think Smile will be okay as for Dr. Faiz.
Yes.
He was asking for Smile.
Yeah.
Okay.
Smile would be here not wrong too, right?
Yeah, it is not wrong.
Okay. The other question, why we don't take K-max anymore in consideration and right now K-mean?
Exactly, because there is no evidence behind Kmax, no evidence at all. The studies, the evidence is behind the Km. So in my old videos, very old videos of tomography, I depended on Kmax, but the later videos, I mentioned that we should stop depending on Kmax, and we have to depend on K-mean, Km.
And it must be under 48, right?
48 if it is pentacam, and below 47.2 if it is Galilei or Cyrus, because they depend on Placido. Placido is more sensitive.
Thank you. Another question from Mariam, why shouldn't we firstly wait for 3 months and control, and after that make a decision for laser surgery?
Yeah, this will be ideal. Yes, this is very good ideal. Yes, I do agree.
Thank you. We
In
can go
such
for
cases, I usually give lubricants and tell the patient come after 15 days. After 15 days, most of the patients with such patterns, they become very normal, very.
Maybe I will not just talk on her behalf, Dr. Miriam, but maybe what she meant, like just see if it's progressive or not. Maybe
Yeah. She
maybe
means
for
that.
like not 15
Yeah.
days. Like I mean, for a good period to check progression.
Yeah. But we start by giving lubricant for 15 days. If they keep staying like this, so in this case, yeah, why not? 3 months, every 3 months monitoring. But if they improve, then done. No need to monitor.
Yeah, that's right.
Fantastic. Very nice discussion. Now, we come to this case. This is the corneal thickness. This is tangential anterior, elevation anterior, posterior, tangential posterior, epithelial thickness. This is the left eye, and this is the right eye.
Does he have history of contact lens wearing and dry eye?
No. Do you see something on this tangential curvature map? Anterior tangential map. Anterior.
There is hot spot, very inferior.
Okay, what else? Previous surgery.
Maybe there is a scar up here, like there is
flat areas.
Very good.
Yeah.
This is the contour of a treated area before. So post LASIK, as they said. Actually not LASIK. I'll show you why it wasn't LASIK. But post refractive surgery. Let's see the one before. You see? Flat here and steep here. Now, let's see okay, let us see. What do you think the reason we have this hot spot in the center?
Actually, there is adjacent ceiling, like behind.
Is it a presbyopia therapy?
A good thinking, actually. And some people are saying a small optical zone, post-hyperopic, because ablation, but usually the ablation is larger than this. Okay. This is the reason. There is a scar. You see?
Yeah.
And this is the other eye. A larger scar. But is it in the stroma or subepithelial?
Subepithelial.
Very good. This is the reason. Bad healing of epithelium after PRK. You see? Bad healing of epithelium after PRK.
Does it reflect on the epithelial map here or not?
Here is the epithelial map. There is a hump under the epithelial map, so there is focal thinning. And this is very obvious. Look, you see the epithelium? It's very thin over the hump. And here as well, it is very thin. Look, almost no epithelium over the hump. So this is very consistent with, you see? Okay, so bad healing of epithelium. Why is that?
Maybe it was a PRK with no mitomycin?
This is one reason. Delayed epithelial healing. This is the most important reason. When there is delayed epithelial healing, we end up with a scar. And the delayed epithelial healing, first, ocular surface disease, meibomian gland dysfunction. This is the main reason. Okay? The other reason is punctal plugs. When there are punctal plugs, the toxins will keep circulating on the surface. They do not drain. And therefore, there will be delayed epithelial healing. Can you imagine that some surgeons, they put plugs for every patient coming for refractive surgery to avoid dryness. And this is a disaster because more infection and more delayed epithelial healing and more scarring. All right? So ocular surface disease, maybe the patient is pre-diabetic. By the way, the steroids do not affect the healing. This is a misconcept that, okay, the steroids will stop the proliferation of epithelium. This is wrong. The steroids will enhance the epithelial healing because they remove the toxins and they will assist the epithelium to heal. So give steroids when you see there is delayed epithelial healing. All right, no, this is not viral infection after PRK. Okay, of course, exposure to UV light is one of the reasons as well. And that's why when you see that the epithelium has not healed after 5 days of surface ablation, you have to act. Don't wait. Don't say, okay, let's wait, let's observe, put a contact lens, remove a contact lens, put another contact lens, remove the contact lens. Don't do this. After 5 days, no healing, you have to act. Check if blepharitis, meibomian gland dysfunction, if there is a plug, remove it immediately. All right? You can replace the contact lens with a new one. Give vitamin B12,
vitamin
C, maybe doxycycline. All right? So you have to act. Maybe if your country, they have the lifitegrast, Xidra, for example, for sure it will enhance. If you don't have, you can give cyclosporine, like Restasis, Vircasia, whatever. This
Would you
will
give
help as well.
something like OmniLens or something, like if it's available, you put an OmniLens instead?
OmniLens, which is what?
Which is amniotic membrane, like it's like easy to access.
No, not at day 5 immediately we go for this. No, we just by manipulating drops. You will find everything will be fine. Yes.
Yeah.
By the way, no, the overdose of mitomycin C does not cause this. No. But the high concentration of mitomycin C may cause this. So it's very important to be sure that the dilution and the concentration of mitomycin C has been prepared correctly, all right? But no matter how long you keep the mitomycin C on the cornea, even if you put it 2 minutes, it will not cause delayed epithelial healing. But if the concentration is higher than what it should be, it will cause delayed epithelial healing. Fantastic.
Just a question, Professor, from me for this case. Do you got it? Could you remove it conservatively, or you have ablated at last?
Yeah, very good. Now, because it is subepithelial, I go, when it forms like this, of course, at the end of the day, when it is like this now, I go and I take the scrubber of the PRK, not a blade, the scrubber of the PRK, and I try to peel it off. And it will be peeled off very easily, without the need for ablation, no need for PTK for this, because it is subepithelial. It is so easy to remove it.
Yeah, you just use alcohol, like you just put an alcohol well and remove this area?
No, nothing,
just like
nothing.
that.
The scrubber itself, I come to this area, I just do just little movements, and it will peel off. It will go out.
Just locally. You don't just remove the epithelium and let it heal again. No.
No. Only in this area.
Okay.
Exactly.
With a hockey knife.
Yeah, exactly. Yes. The hooky. No PTK. No need for PTK if it is subepithelial. This is not stromal. Yeah, epithelial debridement at the site, and then with a scrubber, the piece ball scrubber, then we can remove it. Yes. All right. What is this? This is the right eye, and this is the left eye. Right and left.
Does he have any history of any LASIK surgeries? No.
Yes,
Yeah.
you see the ablation.
Yeah. And we can see even the relative pachymetry, but we are here in MS39, but I need to show it more. Yeah.
Here is the relative pachymetry
Thank
map. You see, the ablation was central, so it is post-myopic treatment.
Yeah, that's right.
And the tangential map, front, it will show you the contour. You see, this is the ablated zone. It was post-myopic. And look at these two spots, which means that there was astigmatic treatment as well, because it is not all homogeneous. There are ablation here and here. So myopic with astigmatic.
Mhm.
Great. And now, this is the question. This patient came for treatment because they still have -1 sphere. And it has been 3 months post this treatment. And they want to remove this. So it is a kind of enhancement.
Yeah.
So what should I do?
It was LASIK or PRK, the previous surgery?
LASIK.
Does he have the flap was big enough? Like what was the flap?
Here is the OCT. It was 112. You see 112.
We'll put it in the formula.
And the central corneal thickness is 482. So 482 minus 112. Then the stroma is what? 0, 3. So do you lift the flap? Do you cut a new flap? Do you do surface ablation?
Let's see, calculate. Like if we do surface ablation, let's just remove 50 first from this 112. Let it be 110. So it will still 60 left. How many we need for this -1 for ablation?
50.
We need
50
like if the
microns.
zone is 6.5, we need
Yeah.
15
microns.
15 micron from the 60. I think it's fine.
Now, this is the epithelial map. You said that, let us assume that it is 50.
Yeah.
Yes, it is 56. Now, this is left eye, sorry. We have to look at the right eye. It is 60.
Okay, 60 and we have 110. So 110 minus 60 equal 50. And we need to remove from the 50 about 15. So the remainder is 35.
Very good. Yes. So surface ablation is better than lifting the flap. So we will avoid what? Epithelial ingrowth.
Yeah.
We will not weaken the stroma more and more.
Yeah.
Now, the question is, do you go for PRK or trans PRK? What do you think? Yes, trans PRK is much better because it's a peace of mind. You don't remove by alcohol, so you are going to make wrinkles in the flap itself. All right, because the flap is already thin, 110. So don't touch the flap. And trans PRK will solve the problem, especially if the flap has wrinkles hidden by the epithelium. So you don't open a box that you don't know what is inside. So trans PRK is the best option in this case.
How many micron, Professor Sinjab, you will leave as a bed for the flap, like in PRK? Like what is the cutoff point, for example?
Yeah, actually, I learned this from many refractive surgeons, experts, and honest, of course, ones, not those who are heroes just to show muscles, that even if you remove the flap altogether, no problem at all. But I don't like this. You know why? Wait, let me remove this. Now look, if we assume that 60 microns, so in this case, okay, so 60 microns. So in this case, we have 50 microns of stroma of the flap, correct? Now, let me assume that I'm going to treat 3 diopters. So in this case, I'm going to consume 45 microns. So we will have a very thin layer, which is 5 microns. I did this once. And then I stopped doing that. Why? Because you have a thin layer, which is 5 microns only. And at the end of the procedure, this 5 micron, it became like this without even touching it. So, of course, the epithelium can hide this, and it went very well. But I will never do it again. Although, as I told you, some surgeons may say, okay, you can remove everything, no problem. No, I would leave at least 20 microns of the stroma flap.
Okay.
Better. Okay, super. Very good questions.
Is epiLASIK an option here by Sarah?
No. Only trans PRK. Now let's see this. What is it? Yes, we have to use mitomycin C after trans PRK in the previous case.
Yeah, this is the same cornea. There is like so far it's just like 450 microns, which is not for LASIK anyway, and it's oblique astigmatism. Look like it's not oblique astigmatism. It's just like it's just as inferior steepening anyway.
Yes.
But still is within the 1.5 here, but there's inferior steepening. Otherwise, the other things. Does he have any LASIK before?
This is the other eye, left
Yeah.
and right.
He didn't have any LASIK procedure before, no?
You will tell me.
Okay.
I don't. I'm giving you this topography because I don't know how to read it. You will read it for me. So did the patient?
Yeah. The left eye is a little bit suspicious of like there's some there's more than 1.5 here, and there's inferior steepening.
There is inferior steepening, but in the back surface, there is no sign of keratoconus.
Good. Perfect.
Let's see the other maps if we can, please.
Unfortunately, they sent us only these 2 maps.
So what's the problem? What they're asking for?
The patient is suffering from glare.
And does he have any history of any surgeries?
The patient doesn't know.
So we will like to have aberration map.
So what else we have available here to say? Like anyway, there is a thinning here. Like if I don't have anything else. Anyway, if we take it, this is
Look at this area, and look at the pachymetry map. It's going
it
up.
could be decentered ablation, yani.
Exactly.
Yeah.
Decentered ablation.
He should
Exactly.
remember this. He should remember that he got a LASIK. Yeah.
Yes, exactly. So the patient actually had, sorry, previous LASIK, yes, but the LASIK was very bad quality and decentered optical zone. This is decentered optical zone. It's very important point that Ahmed mentioned, that inferior steepening, but nothing on the posterior surface. So it is not post-LASIK ectasia. And this is misleading. Many surgeons, when they see this in a patient who had LASIK before, they think that this is ectasia, and they take the patient to the accountant to pay money and then to
Cross-link.
do printing. All right.
He will
So
forget that he paid money already. He forget already that he had a LASIK. Yeah. It will not hurt him too much. Yeah.
okay, so look, even this one is going up a little bit, but nothing on the posterior. This is very important. We call this the contour effect. Contour means that because of the decentered optical zone, the computer of the machine, the device, the topography, will think, okay, will think this area as steep. It is not steep actually, but the cornea is upward. The area is upward. So the border of the treated area is towards the machine, and therefore the machine will think that this is a hotspot. All right, we call this the contour effect. And therefore there is no need for LASIK, for cross-linking.
But if
Now,
the
this is the
symptoms
same patient.
if the symptoms annoying him, why not to do topo-guided
Yeah,
corneal?
of course.
Oh, yeah,
Of
yeah.
course, of course. So
Yeah.
no cross-linking, but of
Oh,
course,
yeah.
yes, topo-guided treatment is mandatory here, of course.
Yeah.
And look at the epithelial thickness map. If it was real ectasia, then we should have focal thinning here. All right? There is a small spot of focal thinning, but not the whole area. And this is the other eye. You see, it is here. There is no focal thinning here, which means it is not ectasia. Of course, topo-guided treatment. Now, what do you think the patient is suffering from? Vertical coma or horizontal coma? Yes, let's see. Look at the vertical coma. It is 0.6, huge. And the other eye, it is 1, not 0 point, it is 1. Oh my God. So the patient is crying. And you know why the decentered optical zone happens? Is it the fault of the patient or the fault of the surgeon? The surgeon, of course, because the surgeon was not watching and monitoring the fixation of the patient's eye during ablation. He was just looking to his side and making jokes with the nurses and the staff to be like very nice surgeon. You know, he has very high volume. He is a pioneer. So making jokes, making a nice environment, and doesn't take care of the poor patient. Okay, so it is the surgeon.
Interesting that both eyes like this.
Yeah, bad surgeon.
Hope not all the patients on the day.
Yeah, exactly. Maybe all his patients like this. Now, yeah, nothing special with this case actually. Let us see this. Now, what do you see here?
horizontal bow tie.
This, again, is the rule astigmatism.
Yes.
And okay, nothing else special.
Yeah.
Okay, nothing
Actually,
else.
nothing else. Yeah,
Yeah.
that's all. It is against the rule astigmatism. All right. Now, let's assume that everything was very normal. Both eyes, all maps, all numbers. And this patient wants to have LASIK done.
Okay.
All right. And the patient has -2 sphere, -2 cylinder. Usually the -2 cylinder at what axis here? Should be at what?
Minus 90 degrees.
Yes, 90 degrees. Now, what precaution if I want to create a flap here?
الهنج.
Exactly. Usually the hinge is superior, and the ablation is usually at the periphery of the flat axis here for the astigmatism. So if the hinge is here, the ablation will hit the hinge and will cause hinge irregularity, irregular astigmatism, and epithelial ingrowth. Now, if the IQ of the surgeon was very high, then the surgeon will take a sponge or weak cell and will hide this area. And the ablation will come on the sponge or on the weak cell. This is very high IQ surgery. Okay, this will cause what? Irregular astigmatism as well, because the ablation superiorly has been eliminated. There is no ablation on the superior part of the flat axis. There will be only on the inferior part. And this is one of the reasons as well of decentered optical zone and irregular optical zone. So the only solution when you see 90 degree or 80 degree or 100 degree is to create the flap oblique, either this side or this side, oblique, at 70, for example, or at 120, for example. And this is very easy if you are using the femtosecond. You can program where the flap should be. Or if you are using as well the microkeratome, if you are expert in microkeratome, where the arrow should be. Okay, in this case, you will have complete ablation at the periphery of the flat axis.
What about smile here? Is there any consideration?
No consideration. You are fine with the smile.
Good. There is a question from Mariam. Please, could you explain hinge?
Explain.
hinge.
Yeah, the hinge is the attachment between the flap and the cornea, because we know we usually make the cut, and then when we lift the flap, the hinge is the neck of the flap where it is attached to the cornea. We call it hinge.
And always in horizontal astigmatism, you will advise to have it oblique, right?
Yeah, against the rule, or oblique astigmatism. For example, if it was oblique astigmatism this way, so it will be fine to make it the hinge here.
Okay, good.
Yeah.
معلش if you don't mind, Dr. Mazen, just say again why you didn't put it like nasal, just why oblique, why you didn't put it nasal or like perpendicular?
Yes. Yeah, very good. You can make it nasal, no problem.
Yeah.
But usually the nasal is not as stable as whenever it is like oblique or superior. You know, if they squeeze, if it was nasal and they squeeze So it will be more exposed to dislocation, to wrinkles like this.
Yeah. Another
Now,
question from Ibrahim. Doesn't the eye tracker prevent decentered ablation or isn't reliable?
no, this is a big lie from all companies. All companies are liars, big liars. No tracker at all can detect the very high movements. They just detect the tiny movements only. Whatever the speed of the tracker is. Now, this is a child coming with this keratoconus. So the child is 10 years old with this keratoconus. So what is the first rule? Be sure it is keratoconus. How? You check on the slit lamp. If there is VKC, if there are punctate epithelial erosions, okay, punctate epithelial erosions because of dryness, they can give you the same appearance. So you put fluorescein drops to check the cornea, and you check the limbus, and you check the full eye. If it is irritated and red, just throw this topography in the garbage, treat the patient, and repeat. Even if it is, the QS is okay, even. So this is the first rule. The second rule is, okay, to be sure that this is keratoconus by anterior and posterior. If it is only anterior irregularity and the posterior is normal, then no, it is not keratoconus. So this is the second rule. The third rule, if it is real keratoconus, cross-link the patient. So what do you think? This is left eye and this is right eye. It is obvious, it is keratoconus. Yeah. And you have to tell the parents, if we do cross-linking, your child should not rub their eyes because cross-linking will disappear. So no eye rubbing at all, before and after. Now, this is the final case. This patient is coming for SMILE. They are willing to do SMILE. Look at their numbers. minus 1.25. Okay, minus 1.25 sphere, minus 8.25 at 4 cylinder in the right eye. All right. While the astigmatism on the topography is just 5 diopters. So there is a big disparity between the subjective and the corneal. So after cycloplegic refraction, we have to do PMT, post mydriatic test, to be sure about the subjective refraction, exactly whether it is really 8. If it is really 8, it means that they have as well lenticular, correct? Lenticular astigmatism. The corneal is 5, and they have additional 3 from the lens, crystalline lens. All right. Now let us see the other eye. The other eye, almost consistent. It is minus 1.5, minus 4.75, and here it is 3.3. So not big difference. But still, it seems that there is lenticular astigmatism. So apart from the final refraction, because the final refraction is the PMT. We recheck the patient after cycloplegic refraction subsided. We check the patient in another day for the final refraction. I do this on the day of the operation itself. And I decide the final number. Now the question here, what is the highest number that we can treat with astigmatism?
For what? For the
Smile.
for the smile? I think it
Five.
was -5.
Yes, exactly. It is -5.
According to the European one, isn't it?
Yes.
Yeah.
So in this case, and by the way, the lenticule, because the sphere is little, while the astigmatism is high. So let us say it as like this. Now we have -1.5 sphere and -5 cylinder, for example. It means that in one direction, the lenticule is for -1.5, and in another direction, the lenticule will be for -6.5. Correct? Because 5 added to 1.5, it is 6.5. So the area, so some area will be very thin edge of the lenticule. So you may find some difficulty in dissection in this area. Correct? Because the lenticule is created based on what we call it, because it is astigmatism. It means that in one direction, it will treat -1.5, the other direction, 6.5. All right. Now, this is the thing about the smile. And of course, we have to tell the patient for this. And of course, usually we add. I multiply I add 20%. If the patient is very young, I add 20% to the sphere, and I add 15% for the cylinder in smile. Always I do this. But if the patient is above 30, 35, then I will add 15% only for the sphere and 15% for the cylinder. And if it is against the rule astigmatism or oblique astigmatism, I add nothing to the astigmatism. Okay, so if any more questions, I'm ready.
Thank you very much, Professor Mazen. These very nice cases. Is there any questions? Here, maybe it's a question. I think there is some surgeons correct astigmatism up to 6 dioptries. What's your opinion?
Yes, we can, no problem.
No
Up
problem.
to 6, it's fine.
طيب. Can I ask you some questions, Dr. Mazen, about just a little bit about the Pentacam and the MS-39? Like, if you have like the thing that we mostly use to the Pentacam setting, and if you are in doubt like this, you started to see more maps, more stuff. What about if you have MS-39 only? Would it
For
be
me,
a
it is
reliable
more
machine only
Yeah.
for doing a LASIK, like setup of a LASIK center?
Yeah. Yes.
But for
Because-
example, in the Pentacam, see a lot of cases we are in doubt. We just see, for example, they don't have the spatial profile in MS-39. They're doing something that Billen Ambrosio, like if you're in doubt, you see Billen Ambrosio. So would it be a different, like very hard to have like only a MS-39? On the other hand, the MS-39 having the epithelial map, which can change completely the decision as well. So what do you think the wisest thing? Because do we have to get like both machines to have the best
No. MS39 alone is more than enough because it has the spatial profile. This is the spatial profile in MS39 and Cyrus.
But it's not the same as the spatial profile we use, isn't it? Like it's slightly different.
Yeah, it is.
It's in Pentacam.
It is.
Where is the
Because
6 millimeter?
this is the percentage, of course, the percentage. The Pentacam has both percentage and like this. Look, it
Okay.
has the percentage. This is the percentage, and it has the absolute numbers. But the percentage alone is in more than enough. Okay, so in the MS39 and Cyrus, look, this is the black one is the one. And the white circle, this is a feature that is not there in the Pentacam. And if you have MS39, you can depend on the posterior curvature map, tangential map. Okay? And you just ignore the elevation maps. You don't need them anymore. All right? And if you have Cyrus, only Cyrus, then posterior tangential map with the anterior axial map, more than enough to check if the patient has keratoconus or not. And if you have MS39, the MS39 has additional epithelial thickness.
That's right. But you mean the anterior elevation map here and posterior elevation doesn't, the numbers that we use in Pentacam, the cutoff points, we don't use it in MS39? Is different, or we can use it still?
Exactly. They do not apply to the MS39. They do not apply to the Cyrus. So anyhow, you have to ignore these elevations.
And just tangential, posterior curvature, and epithelial thickness.
Yes.
And that's more than enough.
Yes. And this one. And this one.
Which one?
Yeah. The
spatial profile.
And the white circle.
Okay. And even the ellipsoid, there's no toric ellipsoid here, like, isn't it?
No, we don't look at the ellipsoid. Just the white.
Best fit toric ellipsoid, there is nothing here like this.
Yes, of course, if you want to check the elevation maps, there is the spheric.
There's best fit sphere.
Yes, best fit sphere, there is. But you cannot apply the numbers.
But I mean, there is no best fit toric ellipsoid, no.
There is, but not in the same name. It is called aspheric toric.
Aspheric toric. Okay.
Yes.
Type. Another question, if you don't mind as well. I was talking to one of my colleagues before the podcast, and he was asking about the premium lens Pentacam. Like if you want to do a premium lens, what you consider in the Pentacam, and does all premium lens need a Pentacam? Because there is some surgeons doesn't use the Pentacam even before putting the EDOF, for example, or something like that.
Yeah, 99%, like the Arab elections, for presidents, they have the 99.99%. Okay, the same. Of surgeons, they don't even do topography for cataract patients. It is mandatory to do topography for cataract patients and to check the corneal wavefront. All right? What you need is only this map. I know there is a special display in the Pentacam for the premium lenses, but it is just a collection of these numbers. What you want to do is to check the asphericity, which is here, and the total RMS of the 5, which is here. All right? If the RMS is more than 0.35, then no multifocal lenses. Very simple. Any other question?
Yeah, there is. I think it's a long question, but okay, I know, like, you can just say it quickly. Like, I have another colleague was asking about in the keratoconus, does always the same point should be on the elevated point, or at the same point should be the same point should be on the elevated point on the map? If it's not, like, we don't put in consideration. In other
Yeah,
words,
I understand.
oh
This
yeah,
is called the notable points or the red
yeah,
on red.
yeah. Can you briefly explain it for us, Dr. Mazen, like if you don't mind?
Yeah, exactly. This is the concept of the white circle here. We call it
Mhm,
the notable points.
mhm,
The notable points. What does it mean? The thinnest point on this map, the thinnest point on this map, the highest point on this map, the highest point on this map.
mhm,
Okay, where are they? The machine will plot them here.
mhm.
Okay, we'll plot them here.
Yeah.
We'll plot it here, for example. So as you see, this area, this. Then the machine will make the white circle, which collects the average of these points
Mhm,
accordingly, and we call this red on red. So if
mhm.
they are very close to each others, the white circle will be very small, like what we saw in keratoconus.
Yeah.
And if they are discrete here and there, it means
Mhm.
that it is the red on red is not significant and the cornea is normal, like in this case.
Yeah. Yeah.
Nice.
And is there something to plot it in the Pentacam, or just is some like one of the facilities only on the MS-39?
No, there is. It is in the in this one, the holiday report.
Yeah.
In the holiday report, the holiday he depends, Jack Holiday, he depends on the tangential front, the relative pachymetry, and the elevation in best fit toric ellipsoid, anterior and posterior.
Mhm,
So, for example, if there were red spot here, if there is red spot here, we
mhm.
look if there is something corresponding on the relative pachymetry map, like a spot of minus values. And
Yeah.
this corresponds to high numbers, plus in this area and in this area. So we call it red on red. Okay,
Good.
but the machine itself doesn't give it like a circle similar to
Okay.
what
We have to check it. Yeah.
Yes, we have to check it ourselves.
Okay, that's very interesting. Yeah, I think that was mostly the just a common question, like say, that was before the podcast. What's the common mistakes in suspicious? Like I think you covered it, and they say what's the common mistakes you find it in the suspicious pentacams. I think we covered it in your own explanation. Yeah, most of them.
Yeah.
Okay. Yeah. So yeah, I don't know. There is why the most patient. One second. Um, Dr. Isa is saying why the most patients in our clinic are not satisfied with EDOF toric.
Very good question.
Mhm.
EDOF and multifocal are premium lenses, and therefore any remaining astigmatism will affect their performance. So they are very sensitive to any remaining astigmatism, and this sensitivity will be even more if they wear toric lenses, EDOF toric or multifocal toric. All right?
Yeah.
And this may happen when there is mismatch between the axis that should be and the implanted axis, maybe rotation of the lens after the operation, whatever. So that's why the residual astigmatism is the main reason why they are not satisfied.
Okay. And
that's why when there is high corneal astigmatism, more than 1.5 diopters, I don't use multifocal lenses, toric multifocal lenses. I don't use toric EDOF lenses. I just tell the patient, let's go for the toric enhanced monofocal lenses because they are more forgiving. The toric monofocal lenses, even if they rotate, and there is residual astigmatism of 0.5, 0.75, the patient will be somehow satisfied.
yeah. There is other question regarding, I think the smile case was a little bit very advanced to understand, to be honest. I think Dr. Basil is
Last
saying,
case.
yeah,
Yes.
the last case, the smile. Did I understand correctly that we should first repeat the auto-refraction after cycloplegic with cyclopentolate? And if the value remains the same afterward, what should be done? What options are available for him to become glasses-free? So yeah, it's a little bit me as well. If you
Confusing.
can, if you go back for this slide, like because it was confusing some stuff for it for me as well.
Okay. Now, let's assume that after we do the cycloplegic refraction, and then we bring the patient after 3-4 days to do the PMT, all right? And still, there is this big difference. And the patient can see with this refraction much better, under many lines, okay? So much better. So we have to say, okay, this is the real refraction of the patient. In this case, no corneal surgeries. I would go for ICL, for example. I check the angle, I check the anterior chamber depth, for example, if it allows. Because if you want to do the subjective refraction of the patient, you are going to flip the axis. If you are going to do this, you are going to flip the axis. After the operation, if you check the cornea, you will find a bow tie, but it became like this. Okay, it will become like this. And the patient will start suffering from high order aberrations because you flipped the axis on the cornea. So whenever a very big disparity between the final refraction and the corneal astigmatism, try to go for phakic IOL options. Or you can treat only the corneal astigmatism and tell the patient the remaining will be treated by glasses.
Or I can just, if it's like I can treat only the corneal and compensate whatever left for the spherical, for the sphere.
This is one of the rules, but if the remaining, for example, is 3 diopters, like in this case, this is 5, while this is 8, so 3 diopters, the spherical equivalent will be you have to take half of the 3 and you add it to this one, so it means that we have to treat 2.75, which is huge. We are going to create overcorrection. So usually we compensate by just adding 0.5, not more than this. Compensate by 0.5 more. Overcorrect the sphere by 0.5, not more than this.
That's too much, yeah.
Yeah, it is too much. So in this case, undercorrection.
Yeah.
Undercorrection.
Yes.
For the left eye, there is a question. Why, or from Sarah, what do you mean with 20% and 15% adding?
Yeah, in the smile, we always add to the numbers, to the final numbers. For example, if I want to treat -2 and -2 cylinder, so I treat 2.4 because this is the rule in smile. I have to add, otherwise you will end up with undercorrection. So I put in the machine 2.5 to 2.4, for example, 20% more. And this one, 15%, so 2.6. All right? In this case, 15, no, 2.3, sorry. Here, 2.3.
According to what you choose 20% and 15%, like you add 20% when you decide to do 15% only.
The 15% always with the rule astigmatism.
Okay.
And for the sphere, I choose 20% to add if the patient is young. And 15% if the patient is above 35.
Okay.
Thank you.
Otherwise, we will end up with undercorrection. So it is not like LASIK. In LASIK, we put the numbers as they are. While in SMILE, we have to add
increase
more.
a little bit.
Yes.
Yes. Another question from Mariam. How relevant is the D value in Belin Bosio for the interpretation of keratoconus?
The D value. Yeah, I consider the D value just like an indicator. If it is yellow or red, it does not mean that I'm going to exclude the patient from refractive surgery. It is just like a red flag. I have to know why. So in this case, I will go back again to all maps and check carefully. Maybe I missed something. And if I find that everything was fine, everything was perfect, I just ignore the D index. I ignore it.
Thank you. Another question. Do you prefer circle or PRK for enhancement after smile? What's your experience?
It depends on the thickness of the cap itself. If I did a cap of 120 already, so no, I will not open it as LASIK. I will do surface ablation of the trans-PRK, for example. And if it was 100, for example, yes, the C cut is better in this case. Is RMS available in all devices? Yes. Why
Yeah,
not
Dr.
LASIK?
Ronnie is saying some people look only at the RMS of the higher order aberration and not only the RMS. Why this is best to look at the RMS
Better.
instead of aberration RMS?
No, the RMS of the high order aberrations, yes.
Yeah,
RMS of the high
I
order,
couldn't
yes.
understand the question well as well. So some people look only at the RMS of the higher order aberration and not the RMS. Why is it
Better.
better to look at the RMS instead of higher order aberration RMS?
Yeah, it
He means the
is.
total RMS, maybe? Maybe he
Maybe
means
he
it?
means the total. No,
Yeah,
we look at the RMS of the high order aberration only.
the total higher. We don't have, yeah, okay. The total.
Yeah.
Okay. So from the attendance, thank you, Dr. Ronnie. From the attendance, any other questions from the attendance? All is good?
A
I
small
think,
question. The
yeah,
Rinke profile is available not in all devices, but in Pentacam. It's a further module which you must book additionally. It's not directly with a standard Pentacam equipment. Okay.
I couldn't understand the question, sorry.
About Syrinki profile, if it's available in all devices.
the Zornike. Is the Zornike in every device or not?
Zernice.
No.
Yeah, Zernice, yes, it is available in MS-39, Cyrus, Galilei. Yeah, all devices should have Zernice, yes.
But I think you just need to pay extra for it. It's an extra module.
Yes.
In Pentacam, only in Pentacam, you have to pay extra.
Yeah, Dr. Farid Nagar is very rich already.
Pentacam.
I know he can pay.
But in MS-39 and Cyrus, it comes by default, and Galilei as well. And Pentacam, they sell you even the chair, the table separately, whatever you want to buy.
Right.
Yeah.
Right. Another question from Ismail. Does the circle in MS-39 has a cutoff of measure?
No,
No.
you can recognize it whether it is very small or it is large. So it doesn't confuse you. No worries.
Okay. Another question for us. The podcast will be posted on our website. It will be available for the members. Our members get a special code to log in and see our library. I have many thanks for Professor Mazen Sinjab that he allows us to record this very, very high value podcast and for this talk and for Dr. Muhammad Hasni. Inshallah, we see us on Saturday in Hamburg. at the end, I thank all of you attendees, our speaker, Professor Mazen Sinjab, and our moderator, Dr. Muhammad Husni. Thank you very much. Have a nice evening all.
Yeah, thank you very much, Dr. Ahmed. Thank you very much, Dr. Mazen, and hope we do it more. And thank you. We have learned a lot. Wallah. It was very interesting,
Right.
and I definitely know that most of our participants are happy as well. So I'll meet you, inshallah, Dr. Ahmed, at the conference. Yeah.
Inshallah. See
جزاكم
our
الله
attendees
خيرا.
in Hamburg too.
Yes. Inshallah. Inshallah.
جزاكم الله خيرا.
Allah
Thank you
barik
so
feek.
much
Allah
for
barik feek.
this invitation, and it was a great pleasure to be with both of you and with such a very, let's say, educated audience, because all the questions were very, very targeted, and it means that they are very well oriented. So I was very happy, really. Thank you so much, everybody, and have a great night.
Thank you very much. Thank you very much. Take care.
السلام عليكم ورحمة
Take
الله
care.
وبركاته.
Thank you. Bye-bye.
Thank you.
Bye-bye.
Bye bye. Assalamu alaikum.
Assalamu alaikum.
والسلام ورحمة الله وبركاته.